Good morning, I am Rachel Caldwell, and I am doing my oral article review on taking kidneys from donors with diabetes. I will be talking about the risk factors and long-term survival of recipients of those kidneys. The name of the article that I am talking about is The Impact of Donor Diabetes on the Recipient Post-Operative Complications, Renal Functions, and Survival Rate in Deceased Donor Kidney Transplantation, a Single-Center Analysis, published by Informa Healthcare. Chronic kidney disease can progress into kidney failure, also known as end-stage kidney failure, or ESKD. People with ESKD try to treat it with dialysis treatments or a kidney transplant. People can wait on the transplant list for years before even getting a chance to receive a transplant, and in some cases, many don't even get the chance to receive a transplant. In the U.S. alone, 808,000 are suffering from ESKD. The transplant list for the United States is rapidly becoming longer because it is the best treatment for ESKD. There are approximately 92,000 on the transplant list with at least a 3 to 5 year wait time, sometimes even more. Some people unfortunately pass away before receiving a kidney, even though they are on the transplant list. Because of the great need for transplants, loosening the donor requirements has become more popular. Diabetes can be rough on the kidneys. They can scar or thicken them and even change the blood vessels around them. Diabetic donors were previously overlooked for specific reasons. Diabetes is more common, leading to diabetic individuals being more frequent sources of donated kidneys. However, this new research in this article suggests that diabetic donors might not worsen the lives of transplant recipients. The study was conducted from May 1, 2018 to April 30, 2021, and included deceased kidney transplant donors and recipients at the Rimington Hospital of Wong University. The donor criteria included people aged 65 or younger, no history of drug abuse, and more. The recipient criteria included individuals receiving their first kidney transplant or those who had previously received a kidney transplant. This study included information from patients from the time they were admitted to the hospital until the kidneys were received, and the care before and after the transplant. Donors had to have a documented history of diabetes and an HbA1c level greater than 6.5%. There was a donor kidney pathology score that tested multiple exams. A score of 0 meant there were no changes observed, but a score of 3 indicated several changes were observed. Each exam was scored separately and then added together. The study had two outcomes, one being the primary outcome and the other secondary outcome. The primary outcome included recipient death or failure of the kidney transplanted. The secondary outcome was the occurrence of delayed graft function in the recipients after surgery. The image shows the pathological scores of donors with kidneys in two groups. Basic background information, medical history, lab results, and kidney pathologies were researched for every donor and recipient. The transplant centers used a standard triple drug regimen to try and prevent the rejection of the kidney. Continuous data was analyzed throughout the study with categorical data. All the statistical tests were two-sided. For example, survival rates of recipients and grafts were calculated for both diabetic and non-diabetic donor groups. The study examined 80 deceased kidney donors and 160 recipients who received transplants between May 2018 and April 2021. They were separated into diabetic donors, or DD, and control donors, ND. The DD group had 30 donors with diabetes and 60 recipients. The ND group had 50 donors and 100 recipients. The overall basic characteristics of both donor and recipients were similar between the two groups. Information was compared after the transplants were completed. This information included initial lab test, terminal lab test, kidney pathology, times, histology. The figure shows the timeline of the study. This study followed kidney transplant recipients for up to 5 years, with an average follow-up of 42.1 months. Importantly, both groups achieved similar short-term and long-term graft survival and mortality rates, as well as comparable renal function by the third postoperative month. The Kaplan-Meier analysis showed that using diabetic donor kidneys did not significantly affect overall recipient and graft survival. Notably, more severe grade of diabetic donor kidneys, LLB and LL1, were associated with poorer outcomes, and recipient gender and pre-transplant antibody levels were risk factors for delayed graft function. Logistic regressions identified recipient gender and pre-transplant PRA positively as independent risk factors for delayed graft function in recipients of diabetic donor kidneys. The image shows the Kaplan-Meier curve analysis and graphs from both groups. While diabetic donor kidneys show more physical damage, their overall mass was similar to non-diabetic kidneys. Recipients of these kidneys had a higher risk of early delayed graft function and slower initial kidney function recovery, but renal function equalized by 3 months. Importantly, long-term graft and recipient survival was compatible and suggests that transplant centers should consider using carefully evaluated diabetic donor kidneys with close early post-op monitoring. This can be an option to expand and open the door of the donor pool to save many lives. The images below show an organ donor license and the current way that they are completing the transplant surgery. This is my works cited page. Thank you for listening, and are there any questions?